Okay, my topic is therapy. It's always been therapy since I started. I had models of therapists like Walter Shelley and Stu Brown, and unfortunately they're gone. So I have to kind of sit in for them. And I thought I'd give you a little quiz. I didn't write this as a question. What's agorrhagia? Anybody have an answer to that? What's the word mean? Okay, it's a more youthful appearance than one's true age. So this is the agorrhagia conference that I attend each year, and I love it. There are several internet groups that I recommend. This one came into business this last year, the Facebook, the board-certified dermatologist, and Kathy Faraday is here at this meeting, and she sent this one in. Tina Kinsley's Easy Flushing Treatment. Mix 1 bottle of Afrin with 1 bottle of CeraVe, shake, put on in the morning. Well, George Leal on RX Derm recommended this exact same treatment 15 years ago. So I'm the new owner of RX Derm, inherited from Art Huntley, and there's 1,500 members all over the world, and Pam Bazick, who's here at this meeting, is the list mom. What did I spell wrong? What? Oh, you told me that last year, and I didn't correct the slide. I'm sorry. I'm sorry, Pam. Anyway, write to Dr. Pam7 at Gmail if you'd like to be on the RX Derm list. It's a high-volume list. There's Art, our founder, and Rivka, who's here at this meeting, his wife. So we're going to talk about a few different things today. This one's very interesting to me because Haley is really a difficult disease to treat. And this report of treating it with systemic low-dose naltrexone is fascinating because you can get low-dose naltrexone. I bought 100 pills for $130. That's 3 months at like $140, $40 a month. Very, very cheap therapy. 4.5 milligrams given each night has basically no side effects, and the only side effect that's listed is intense dreams. I thought, yeah, I'll take that. So there were 3 cases reported in the JAMA Dermatology this year, and they had complete clearing of their erosions with low-dose naltrexone. So I've always said, quoting Dick Dobson, that treat diseases of unknown cause with medications which have unknown mechanisms of action. And I think this is true of naltrexone. Naltrexone has been reported to have a toll-like receptor antagonism, and toll-like receptor 4 is present on keratinocytes, and keratinocytes have opioid receptors, and low-dose naltrexone interacts with 5 different opioid receptors, including the mu receptor, which is on keratinocytes, and it's felt that the activation of these mu receptors or blockage of these mu receptors by low-dose naltrexone makes keratinocytes grow correctly. That's a theory. I don't think anybody's proved that. This is from the JAMA article showing one of the 3 cases. It's pretty impressive. All 3 cleared up over a period of several months. What do you think the common chemical is that reverses progeria? Botox? No, it's methylene blue. And I wrote this up actually in 1989 in an article called Therapies You Probably Never Heard Of. So next year I'll give you a talk about methylene blue. But the authors of that paper from the University of Maryland said that methylene blue can also reverse the effects of normal aging in healthy cells, including damage to mitochondria. And they're going to start doing tests on animals and eventually people, hoping that this non-prescription, horrendously cheap powder, I have cans of it at home, we use it for a swimming pool, that it might reduce aging. And it's certainly, I've never seen a patient with progeria in my practice, but I did. If I ever did, I'd put them on methylene blue. Making sense of Demodex. One of our residents said, "What are you going to talk about at the meeting?" And then waited a second and said, "Demodex?" And I said, "Yeah." And he says, "I thought so. There are slides all over the clinic covered with Demodex. Where did you get them?" And I said, "From my face." I'm a perfect example of demodicosis. Demodex causes scaling, redness, telangiectasia, anywhere you find it. So just recently, in September, in the JAD, there was a big review of all the articles that talked about Demodex and rosacea, all put together in one article, a meta-analysis. And their conclusion was Demodex may play a role in erythematotelangiectasia, read it. the red rosacea and papulopustular rosacea. So, so, so I was fortunate enough as a very first year resident to have Sam Ayers Jr. as one of my attendings, and Sam Ayers the second, his son, was my teacher of hair transplants. So I knew the Ayers quite well. And when we just mentioned Haley and Haley disease, Sam Ayers and his son sent in a definition of benign familial pemphigus 1 month after the Haley brothers mailed their paper. It would have been Ayers and Ayers disease if it hadn't been published first as Haley and Haley disease. But Samuel Ayers and his business partner, Nelson Paul Anderson, were giants of dermatology in Southern California. And in 1928, they presented a paper on Demodex causing rosacea, and they also presented it again in 1931 at the ADA meeting in Toronto. So here, these guys defined what causes rosacea 70 years ago, and a month ago, there's a paper going, does Demodex cause rosacea? You know, it's like, how could we, for 70 years, ignore what these guys taught us 70 years ago? And they noted that Koch's postulates couldn't be fulfilled because Demodex is a normal inhabitant of human skin. But these are direct quotes from the article. Demodex follicularum is frequently found in considerable numbers in superficial milky vesicles or pustules or in follicular scales in cases of acne rosacea, and the organism is not found at all in acne vulgaris. Many patients with rosacea in whom Demodex is found give a history of infrequent use of soap and water and excessive cream. These mechanical factors theoretically would tend to favor abnormal proliferation of Demodex. The vigorous use of strong anti-parasitic ointments has been attended by improvement or virtual cure. In all cases, the clinical improvement has been attended by diminution or total disappearance of Demodex. And in his article, the patients were women who washed their face not at all. They took off their makeup and they cleaned their faces with cream. In my current job at the VA, I see Demodex, probably 1 out of every 5 patients has demodecosis, and these are old people, and as you know, old people just don't wash as much. It's true. And they made the diagnosis by removing a drop of pus from a pustule and being real careful not to squeeze it, putting it on a slide, putting KOH on it. Or they took a very fine forceps and picked out the little individual scales from the follicular ostia. And they noted how difficult it was to kill Demodex, and this has been proven again even more recently, because it's extremely tenacious of life, and the only thing that they found that would kill it was an ointment, sublime sulfur, beta-naphthol, balsam of Peru, and petrolatum. The contact dermatitis people would have a thrill with that stuff today. So Demodex abscesses, we've all seen these. They look like horrible rosacea. And Schaller, Sander, and Pluig described a case of demodecosis which was resistant to everything: isotretinoin, terbinafine, dapsone, trimethoprim sulfamethoxazole, roxithromycin, oral and topical ivermectin, permethrin, lindane, benzyl benzoate, all these things that should have easily killed it. And when I tell people rosacea is due to Demodex, they often hoot at you because they say, well, I tried treatment with ivermectin. How often did you use it? Well, I gave it to them once, and then I repeated it in a week. It takes a lot more than that. I borrowed some images from Dr. Karali, one of the residents who presented these really interesting cases from Istanbul. And if you look at this lady, what would you say is wrong with her? What would your first impression be? Say again? My first impression was, this is steroid rosacea. It's involving the eyelids, and whenever you see involvement of granulomatous papules of the eyelid, the outer canthus, that's almost always someone who's been putting clobetasol in their face. And here she is after treatment with oral ivermectin, and oral ivermectin is hard to get in Turkey, but she was given 200 micrograms per kilogram per day for several months. Here's another one. And look at the same pattern. Look at the eye involvement. That's topical steroid use. And the resident said she didn't give a history of using topical steroids, but I have never seen a person look like this who wasn't applying steroids to their face. So Rosacea, secondary to steroids. Perioral dermatitis, secondary to steroids, is Demodex. And here she is also after treatment with oral ivermectin. And the parallel universe exists because I have patients who've come to me with rosacea, and I say this is due to Demodex. Well, I've been to 4 dermatologists. They didn't say that. And I say this to dermatologists at meetings. They say, Haines, I've never made the diagnosis in my life. You must be living in a parallel universe. This is a big review article that was in JAD, Fortin in Belgium. They asked 9 dermatologists to participate in a study on Demodex, and 5 of them, these were seasoned, older dermatologists, had never made the diagnosis in their life. So they were treated to an educational seminar. This is what demodicosis looks like. After they had learned what it looks like, learned how to diagnose it, they made the diagnosis so frequently that it was the 9th most commonly made diagnosis in Europe. So in making sense of Demodex, one has to take into account the life cycle of the organism. They crawl around, they inchworm their way around at night, come out of the pores, and inchworm their way around looking for a mate. So if you want to find Demodex on somebody, you only find it when they're out of the pores at night. So you take a piece of Scotch tape, you give the patient a roll of Scotch tape and about 5 microscope slides, and you say in the middle of the night, if you wake up to pee or drink water, pat your cheek with the tape and stick it on a microscope slide in the dark. As soon as the light comes out, they hide. So it's in the dark, pat your cheeks and your forehead. That's where the resident found all these slides on my microscope with Demodex on them. I'd been doing this to see how much was on me. There was a lot. So this group from Ireland decided that they were going to try and kill Demodex, and they got Demodex off of eyelashes, put them in 70% alcohol or 10% povidone iodine, and found that they didn't die. But tea tree oil did kill them. So they got rid of Demodex on the eyelashes with tea tree oil. I would find that a little hard for me to do, putting tea tree oil on people's eyelashes. But this is the classic Demodex blepharitis. So in my way of treating Demodex, face washing is number 1. Just mechanically scrubbing off the oil before you go to bed. Many people don't wash their face at night. Use tea tree oil soap. That's less likely to give you contact dermatitis or get in your eyes. So, and it gets them to come out of the pores. These doctors in Ireland found that when they used tea tree oil, the Demodex mites came crawling out. They didn't like the stuff, and it made them come out. So if you wash before you go to bed with tea tree oil soap, they will come out so that whatever you put on at night to kill them can get them. I like ivermectin topically as my best treatment. Crotamaton works, but Fortin's group in Europe showed that it takes 2 months of nightly use of crotamaton to kill them. Camphor oil works great, and you mix it 50-50 with glycerin. The two together, camphor oil you can buy for $4 for 2 ounces on Amazon. Glycerin's another couple dollars. It smells just wonderful. I love the smell. Permethrin cream, over-the-counter permethrin cream works, but it's quite drying. So if you're going to use permethrin, you have to use something in the morning that's hopefully not too oily. I think just plain hydrocortisone over-the-counter, 1% works fine for that. Remember how sodium sulfacetamide was on the market for rosacea? There are about a dozen different brands. Sulfur kills them. I don't know where the sulfur preparations went. And doxycycline works for rosacea because inside the Demodex mite, there's a bacteria called Bacillus oleronius, and Bacillus oleronius provides the vitamins for the organism to stay alive. So if you kill off their gut flora with doxycycline, they die. That's how doxycycline works in rosacea. And that was discovered because veterinarians thought heartworm has a bacteria in it called Wolbachia. And veterinarians thought, well, maybe Demodex, like in dogs, has Wolbachia inside them. They tested Demodex in dogs, they tested Demodex in humans, no Wolbachia, but this Bacillus oleronius is in Demodex, and patients with rosacea have very high titers of antibodies against this bacillus. My former wife died of lung cancer, and she was treated with Erbitux, and this is her chin. She developed this very acneiform eruption, which responded dramatically to topical ivermectin. So this has been reported by a number of people, this acneiform eruption in epidermal growth factor inhibitor patients. And here's one that just came out in JAMA. I want you to notice the telangiectasia, how red his face is. The redness isn't the growth factor inhibitor. The redness is a reaction to Demodex. And after a month of topical ivermectin, look how less red his face and especially his forehead is. Another article, this one's from Europe, and in this article, this gentleman had extensive Demodex, and the bottom pictures are confocal microscopy of the organisms in the skin. And here's after a month of topical ivermectin. In his last years, Sam Ayers espoused the use of vitamin E, and he used to say, it has to be D-alpha tocopherol, and he stressed the D, I don't know why. But the reason it works is because it alters the lipids in the skin. And if you ever want to see how it prevents lipids from going rancid, put a capsule or two of vitamin E in olive oil. You can leave it on your counter all year and it won't go rancid. So one of the things I tell people here is be the person your dog thinks you are. And so that's one of my dogs. And I shouldn't be out of time unless you chop my time down for this talk.
Oh, okay. Like 5 minutes?
Yeah.
Yep.
Yeah. If you don't mind. If you all don't mind. A low-fat diet. We're talking about lipids. A low-fat diet prevents people from getting actinic keratosis. This was in the New England Journal, and they had the patients on a very low-fat diet for a year, and the new AKs in the control group were 10, and the low-fat diet group there were like 3. So we heard Matt talk about the polypodium. All kinds of biologicals or botanicals can be given orally, and these are all antioxidants, and they will prevent actinic keratosis formation. Green tea is one of them. Silymarin or silibinin from milk thistle is another one. Grapeseed extract is another one. All kinds of ones. It's very clear that the lipids in the skin of patients with actinic keratoses are oxidized. So that's my theory of skin cancer. It's oxidized lipids. And I'm not the only one who thinks that. If you notice on this thing on the right side, it says TREG. Ultraviolet radiation brings Treg cells, T regulatory cells, into the skin. T regulatory cells inhibit normal lymphocytes from coming in and killing things. They're what prevent autoimmunity. And so I think that what you have is a lymphocyte host response to abnormal oils, which leads to hyperkeratosis. And whenever you see a band-like infiltrated lymphocytes, just think of all the conditions like a lichen planus where the epidermis thickens and you get hyperkeratosis. And lichen planus, hypertrophic lichen planus mimics squamous cell carcinoma clinically. Well, Steve Cassard at UCSF wrote this paper in 2004, and I've talked about this many times because it's so important. We all see old people, especially old ladies, with squamous cell carcinomas or keratoacanthomas that are multiple on the shins, on the lower legs. And on RxDerm, on our internet thing, every 6 months someone says, I have an old lady with multiple keratoacanthomas, what should I do? Mohs surgery, what should I do? Well, they look like this from Steve Cassard's article. They can be anywhere, but they're mostly on the lower legs. And Cassard's group thought that these were on a pathway toward neoplasia, like a lichen planus-like pathway. So I have a lot of patients. Here's my worst one. Legs look like this. This is what hypertrophic lichen planus looks like. This is infundibulocystic hyperplasia, mimicking lichen planus, and always diagnosed as squamous cell carcinoma. I can't tell you how many patients I have with this, these multiple keratotic plaques on the shins. So there's before. I treat them with Protopic and clobetasol, alternating back and forth, and there's the same leg 6 months later. So when I have a patient with too many AKs, or especially these people with them on the legs, I treat them with topical steroids. Yes, topical steroids. And I used to do that just empirically, and I think I might have even learned it from Stu Brown. But I mix Lidex or triamcinolone ointment with Cetaphil lotion and apply it. It's easy to apply stuff. This is what a imiquimod does to people's lips, treating actinic cheilitis. For years, I didn't understand why steroids would make AKs go away. I just found that out this year. This was in the British journal, Pre-Treatment with Topical Glucocorticoids enhances the anti-tumor efficacy of imiquimod. Long-term follow-up, they had a bunch of patients with Bowen's disease, and what they found was that the FOXP3 positive T regulatory cells in the skin were inhibited by topical steroids. Once they got rid of the T regulatory cells, which kept the normal lymphocytes out of the area, then the normal lymphocytes could come in and kill the tumor when they applied imiquimod. So here's some pictures of some of these where you see the FOXP3 cells after steroid application. The middle column, they're all gone. Steroids get rid of them. So now the body can attack them. And here's, you can see the FOXP3 cells are gone with the steroids. The CD3 T lymphocytes, which are killer cells, and CD8 killer cells came into the area. So I'm running out of time, but you can do a lot of literature searches looking at tumor-infiltrating T lymphocytes and their regulatory effect on squamous cell skin cancers. And patients with metastatic squamous cell skin cancer have a lot more of these Treg cells in their tumors than patients who don't have metastatic squamous cell skin cancer. So I'll quit because the time's running out. The topic I didn't get to, which I'm going to tell you you can just remember to look it up, zinc sulfate, 25%. Solution in water, gets rid of actinic keratoses beautifully with no side effects, no redness, no scaling, no soreness like 5-FU. And the way it works is zinc activates the normal lymphocytes and kind of pushes away the Treg cells.